Well, thanks very much. And I live in the CLL world, both as a patient and as the co-founder and the medical director of a not-for-profit, and is on the steering committee of CLLAN. And it's so interesting to hear this talk because there's so much overlap. And I'm going to talk a little bit about some research that we did. But because the MPN people weren't in the CLL lecture before lunch, I'm just going to talk off the cuff for a minute or two about some of the similarities. So, and this will be a little bit redundant for the people who are in the CLL because Dr. Gia went over this. But first, and I'm not going to spend time on the psychological issues because Pierre is going to be talking about that later. Yeah. But so you get this diagnosis that you have CLL, and then the doctor says, see ya, we're not going to do any treatment. So, why is it that they say that? And the reason they say that is there is no evidence that early intervention prolongs life, improves the quality of life, does anything other than feel like you're doing something. This is based on some early data with some drugs that weren't so good. There was a study that was done decades ago looking at a drug called Leukeran or chlorambucil, which compared treating patients early with chlorambucil versus watching and waiting them. And the study actually showed a little bit of a trend to the patients who got the Leukeran doing worse than the patients who had no therapy at all and waited till there was indications for treatment. So in CLL, there's a lot of reason to consider whether you should, when you need treatment, and there's very strict criteria of when you need treatment. Now, the treatment landscape has changed. At least in some countries, we have access to much better drugs that are much stronger. So people tried to do a study that compared FCR, fludarabine, cyclophosphamide, and rituximab, which is a very potent chemotherapy, which has a significant response rate, and some of those responses are complete remissions, and some are minimal residual disease undetectable. They can't find any evidence of the disease down to 1 in 10,000 cells. And so he said, okay, maybe we'll start with that and put you on FCR. And they did this trial where they compared FCR to watching and waiting. They didn't wait for people to need treatment, but they couldn't get people to enroll because, like most CLL patients, want to make their own decision. I mean, I don't want a lot of patients say, I don't want chemoimmunotherapy unless it's indicated that I need to have it now. And other patients said, yeah, treat me right away, doc. So it couldn't randomize. People wanted to be involved in that shared decision-making, and that trial never enrolled. Now, there is a trial that's ongoing right now. There's one being done with the German consortium. Dr. Michael Halleck is leading that, and there's another that John Bird at Ohio State is doing that is looking at ibrutinib or ibrutinib in combinations with high-risk patients, patients that are thought to progress more quickly. That trial is enrolling, but it'll take years and years and years for it to play out. So at this point, watch and wait is outside of a clinical trial, there is no medical evidence that it needs any kind of treatment. So that's what's going on. So it sounds a lot like what's going on in the myeloproliferative world too. So I just wanted to share that kind of background and summarize for my CLL friends what's going on. What I'm going to present is some data that we presented at the American Society of Clinical Oncology in the EHA meetings earlier this year that talks about this. So it's a little bit of our research, which I'm really very proud of to have been involved with this. And this is lists of some of our collaborators. And if you know the CLL world, these are kind of the who, at least in American CLL world. So the literature in CLL focuses mainly on how do I manage the disease, how do I treat it, what's going on, but it doesn't really look at what's the patient's experience, even though the doctors at their best try to educate and reassure patients in terms of what's going on. So the CLL is a not-for-profit that kind of tries to look at the areas of diagnosis, education, and we did this research that covered the whole spectrum of the patient journey from the moment of diagnosis to what their health team looked at, what education they got at what times, in the whole area. So the term you're going to find in the medical community is active observation. So watch and wait is not used as much now these days in the medical world. I'm just going to also say this is a changing trend in the rest of medicine. So men who are diagnosed with prostate cancer, have low-risk prostate cancer, often enter active observation. There's no reason to treat them, and they're often observed for life and have a normal life expectancy. So the active observation, prognostic testing, clinical trials, we looked at all this journey, and I'm just going to present our data in terms of what the patient's experience was like. And we presented this to the physicians because once this becomes part of the medical literature, then it can be used to help physicians communicate with their patients and understand what their patients are going through. So our objectives to understand the CLL in terms of the symptoms, physical and emotional, at these different times, to assess the experience of patients and watch and wait active observation, including psychological experiences and physical experiences. And we also looked at clinical trials, but we're just going to focus on the middle part. So what we did is we set up a survey at the end of 2017. It was 64 questions, and thank you to anyone here who filled that out. It was a long survey. It was available online. We had institutional review board approval, and we looked at the patient's perspective on all of these different things. It was also available in paper versions for people who didn't want to do it online. It was distributed out of doctors' offices, and not only out of CLL experts, but out of community hematologist office. So we'd have each CLL expert on the team give us the name of 5 community hematologists. We'd send the paper versions to them to hand out to their patients. So it was a real mix of people, and I think we had 49 of the, it was only US patients, had to be over 18, had to have a diagnosis of CLL or SLL, but I think we had either 48 or 49 of the states represented. So this is like the card here that patients were involved. We try to promote this on a number of the forums and stuff and let people know about it on my blog and stuff like that, and that's how we set it up. So the median age here, when we looked at it, was a little bit younger than you normally see. The average age in CLL is 72, but people who do surveys tend to be a little bit younger, and you can see the breakdown here. And normally there's more males, but in every survey that we've ever done, there are always more women completing the survey than men. So that's just the way it is. It's very white, the survey that we did. That's what we get when we do CLL stuff. And we can see the average age from time of diagnosis is 5 years. And this is a breakdown of people who are seeing a CLL specialist or just a general hematologist. You can see it's fairly evenly split. So we're able to reach out into the community and get a sense of what that was like. So we can see that about more than 4 out of 10 of our patients were in watch and wait. They could talk about watch and wait, whether they were in it or had been in it. And you can see this is also a breakdown of patients who had 1 and 2 therapies. So I'm going to spend a minute before we get into watch and wait on just one thing that's very interesting here. And that is when patients are diagnosed with CLL, the messaging they get from their doctors can be very critical. And almost half of our patients were told by their doctor something to the extent that they had the good cancer. Now, how you can put the word good and cancer into the same sentence, I don't really understand, you know. But, so just raise your hand if you're a CLL patient here. There's just a few. All right, a few. And keep your hand up if you were told something along the lines, I had a good cancer, or if I had to choose a cancer, it's the one I choose, or you'll have an... So most of the hands stay up here, you know. It's just a very common thing that we want to do. The doctors think they're reassuring us, but they're not. They're just creating more cognitive dissonance. You know, if I had to choose a cancer, this is the one I'd want. We will die with CLL, not from CLL. But, you know, CLL, like MPN, is very heterogeneous. You know, everybody has a different flavor. So now let's switch to active observation. So in CLL, it's very rare to need treatment. Now, you might need treatment only 6 months after diagnosis, but it's very rare to need treatment, and that's what we found. 87% of patients didn't need treatment within the first 3 months of therapy. So for that 87%, most of the patients said their doctor tried to explain why treatment wasn't oriented. But that didn't help all that much. And we can see that over 56% patients were anxious when they were told this, that about half were relieved. Oh, that's great, that's good, but only half were relieved, and a full 31% were confused. I mean, what's going on? So despite the doctor trying to explain it to them, they really didn't understand. And we can see here that the anxiety numbers here, and in fact, were higher in the female population. The confusion was higher in the female population. And when we look at the age distributions, we can see some differences in terms of the older and younger patients. What about symptoms? So active observation, this is not a passive time for patients. Patients are very active during this time. Even only 17% said there was nothing going on. There was no disease issues. Men were more commonly asymptomatic, or maybe they complain less. I don't want to be, make any gender generalizations here, but it was statistically significant, 22 versus 13%. And also, those who were older were less symptomatic than those who were younger. The younger patients tend to have more symptoms, again, 21 versus 12%. In the most common symptom, no surprise, fatigue. More than 6 out of 10 patients had fatigue, enlarged lymph nodes, and anxiety. And I can tell you with enlarged lymph nodes, you're checking them all the time to see what's going on. Are they getting bigger? What's going on? Sometimes they're painful, can interfere with sleep, other problems. We also ask patients, because if my doctor isn't going to treat me, then I'm going to treat me, and let's see what I can do. And we found that 2/3 of our patients were using some kind of alternative or non-traditional intervention to manage their CLL during this period. So this is really important data for their hematologist oncologist to know, because there can be interactions, there can be other things, so they need to know what's going on. So again, this was less common in the older, and 3 out of 4 of the patients under 65 were the ones who were using this. There was not a lot of difference in the specifics. It's interesting that women used more vitamin D in prayer, so I don't know what to say about that. The most common herbal treatment that was used was green tea or derivatives of green tea, and that's based on a study in Mayo, and a very small study that showed that it may slow the progression of disease for some people. Vitamin D, again, some studies have shown that people with higher levels of vitamin D at the time of diagnosis have better prognosis. That does not mean that taking vitamin D improves your prognosis. It means exactly what it said. If you had a higher level at the time of dosing, you do better. But it doesn't mean adding vitamin D adds anything to the picture. Prayer was very commonly used, and the things that didn't make this list but are on that list was curcumin or turmeric is very commonly used. Acupuncture was used. Change in diet was used. I became vegan, when I was diagnosed 13 years ago. Increase in exercise was used. So people used a lot of different things, but these were the 3 top statistical ones. So in conclusion, this is, as far as we know, the largest study of CLL patients. 1,147 patients completed this study, and we'll be having a paper at ASH that'll actually be talking about how they make treatment decisions, how we make treatment decisions. And so we believe that this is a valuable way to find out about patients. And this is, when you talk with docs, I've talked with a lot of docs, being a doctor, and I've talked at EHA and things like this. And if you get up and say, I'd be very interested in the patient's perspectives here, my fellow patient's perspective. You get up and say, I go through this and that. They say, oh yeah, another patient anecdote, a story. They don't. But if you get up there and give statistics and say 62% of 11,487, they're listening. And if that's been approved by an institutional review board and you're presenting it as an abstract, you got their attention, and that's what I'm trying to do here, is take what are individual stories, collaborate them, and then make them part of the medical literature so that the docs will listen to their patients. Say, oh yeah, fatigue, that's 6 out of 10 patients like that. So when my patient is complaining about fatigue, I should really be listening to that. So active observation is hardly a passive period. It's a very active period. It's full of symptoms, both psychological and physical, and patients are trying to do something about this. They're actively searching for alternative therapies to help control their disease. And I'll just finish by thanking CLLAN and MPN for inviting me here. Here's where I left, the California beaches. So thank you, everyone.